Hello, I'm Dr. John Wright. I would like to spend the next 20 minutes with you explaining about cataracts and cataract surgery. I've been in practice since 1982. I'd like to begin by reviewing the anatomy of the eye. The eye is set up a lot like a camera. There are some lenses on the front portion of the eye that focus the light back here on the inside of the eye. The inside lining of the eye is the retina, which would be similar to film inside a camera. And the lens of interest is the natural lens called the crystalline lens that sits right behind your pupil. Cataracts are part of the normal aging process. The lens in the eye continues to grow throughout life. It puts on a layer of new cells periodically, just like a tree puts on a new layer of bark. In fact, if you look very closely, you can actually see rings, just like you could count tree rings. And that continued process of adding more protein material to the lens and having the old fibers get compressed to the center is what eventually leads to cataract formation. Typical cataract will look sort of amber or brown colored due to this process. This is the reason why when you hit your mid-40s you need reading glasses, because the lens is getting bigger and bulkier and loses its ability to flex. And cataracts can occur actually at any age. Even a baby can be born with a cataract. When we see cataracts in younger people in their 40s or 50s, sometimes that variety of cataracts can be caused by steroid use, radiation, history of trauma, but most frequently we really don't know the cause. It doesn't really matter because we fix all cataracts the same way, so the success rate is equally good regardless of what caused the cataract. And now that you have a little information about what a cataract is, let's discuss cataract surgery, when it's appropriate, how we do it, potential complications. So cataract surgery is required when it interferes with your ability to see and do the things that you like to do. Naturally, that's going to be different for an airline pilot than it might be for a person who's in a nursing home. So most of us fall somewhere between those extremes. But when you get to the point where you're not able to see to do the things that you like to do, like driving a car, reading, things like that, then that's probably the right time to do surgery. In the old days, we used to have to wait until each eye was ready for surgery, and so they would use the term wait for a cataract to become ripe. That's no longer the case. We now remove cataracts even on just one eye if it's required. So let's talk a little bit about how we correct cataracts surgically. I would preface it by saying there is no non-surgical method that I'm aware of to remove or correct a cataract. There's no medication or eye drops that are effective. Otherwise, why would we operate? Everybody's anxious about having their eyes worked on, and that's why we use IV sedation. So during the surgery, you'll have an IV in the back of your hand. Through the IV, we can give you some sedation to help you relax. We will anesthetize your eye with topical drops. We no longer need to use needles or injections in most cases. If we're operating on both eyes, we usually do them 1 to 2 weeks apart. We do the surgery by using a little device that holds the eyelids open. There's no pain with that. We make a small incision at the edge of the cornea where the clear cornea meets the white part of the eye, the sclera, and we make those incisions about 2 to 3 millimeters in width. We then use an ultrasonic vacuuming device to remove the cataract. Lasers have been tried, but we find that ultrasound is the most efficient, effective method of removing a cataract. The lens itself, which at this point we would call a cataract if it's turned cloudy, is surrounded by a capsule or a sac, in the same way that a grape is surrounded by a skin. We begin the surgery by making a round opening in the front surface of the capsule, and then we use the vacuuming tip with the assistance of the ultrasound to vacuum all the lens material from the sac, so at the end we're left with a hollow bag. So we're essentially exchanging a clouded lens for a clear lens. We do that with a lens implant. I have here a sandwich baggie to represent the capsule, and I have cut an opening in the front surface to represent how we've removed the cataract from its capsule. Once we have an empty capsular sac, we then place the implant through this opening. In this case, I'm just going to let my hand represent the implant. We slide that into the capsule, and then the edges of the capsule scar down almost like a shrink wrapping process so that the implant is securely trapped. And that prevents the implant from jiggling around or becoming loose inside the eye. The implants are similar in size to the lens that you're born with, and they come in different powers, just like contact lenses come in different powers. So preoperatively, we take measurements on your eye to determine what power implant would work out best for your eyes, with the guidance you give us as to whether you'd prefer that we favor distance vision or favor reading vision. One thing I'd like to mention is if you have previously had LASIK, PRK, or radial keratotomy, these surgeries decrease the accuracy of lens implant power predictability. We need to keep your two eyes within balance of each other. If you have a very high prescription, either very nearsighted or very farsighted, and we take one eye and correct it completely to distance vision, you would then have a very thin lens on one side and a thick lens on the other, and you'd likely have double vision. So the eye that one eye is either going to magnify the image compared to the eye that we worked on, and you get a double vision effect from that, or if you're very nearsighted, it will minify the image, and your brain will have trouble putting those two images together. So we need to keep your eyes within about 2 diopters or 2 units of power of each other. The only way around this is if you wear a contact lens in the unoperated eye, or if you chose to have LASIK on the unoperated eye. Glasses would not be an option. I would like to emphasize that cataract surgery is not LASIK. The objective in cataract surgery is to remove the cloudiness from the eye and to give you the best vision that we can, but we cannot promise you that you will be seeing without glasses. And sometimes when patients say they would like their vision set for distance, I'll hear them say, well, then I'll only need some reading glasses, right? And the answer is no, you'll probably need glasses to fine-tune even your distance vision. We have tried all different types of implants, and we find that patients see best with a standard lens implant that we now use. The standard lens implant can give you a single focal point that will either be set for distance, intermediate, or reading, but not all three simultaneously. So far, medical science has not produced a lens implant that has flexibility like what we see in a 20-year-old eye. Theoretically, if an implant had some kind of a flexible gel that could be injected inside the capsule, that could restore flexibility and what we call accommodation, which allows you to see distance, intermediate, and up close. That technology, as of the day of this taping, does not exist. So we try to get it as close as we can, but nevertheless, our accuracy is plus or minus 1. What that means is, even if you tell me that you want your eye set for distance vision, there's a chance that it may be blurry in the distance, and you may actually see better up close. So if we have done our best to give you the distance vision or reading vision that you have requested and you're still not satisfied or happy with the result, it's probably safer to use LASIK to fine-tune your result rather than go back to the inside of the eye and exchange your lens implant. There's just fewer complications that could occur. What I don't have control over is the way your eye heals. You'll remember earlier we were mentioning how the capsule shrink wraps around the implant, and that can shift the implant ever so slightly backwards or ever so slightly forward, and that does affect the way you eventually see with the naked eye. So I think cataract surgery will never be 100% precise in forecasting how you see without glasses. Now let's talk about the potential complications that can occur with cataract surgery. First of all, blindness is extremely rare and not very likely to happen. The way it could potentially happen would be if you got an infection. If you got bacteria that set up an infection inside the eye, we treat that as an emergency. You would know it right away because the vision becomes very, very blurry, and there's a lot of pain with that. If you developed an infection, that means bacteria has gotten to the interior of your eye. We would work along with a retinal specialist, and you probably would have to have the vitreous gel removed from the eye, along with intensive antibiotic treatment. If an infection is diagnosed and treated early enough, usually we're able to save the eye. Infection occurs in about 1 case out of 1,000. The most common complication that can occur with cataract surgery is a ruptured posterior capsule. That means that sometime during the surgery, either a split or a tear or the ultrasonic vacuuming device created a little hole in the posterior capsule. The posterior capsule acts as a partition that keeps the vitreous gel in this chamber of the eye separated from the front third of the eye. If that were to happen, we do have specialized instrumentation that can remove the gel from where it doesn't belong. Sometimes we can still use a lens implant that fits back behind the pupil. Sometimes we shift to an implant that fits in front of the pupil. Either way, you're still likely to get good vision despite having that problem. A ruptured capsule occurs in about 1 patient out of 100. However, sometimes even with perfectly performed surgery, we can get swelling in the retina. This is referred to as cystoid macular edema, and it affects the macula. This can drop the vision down to very blurry levels of vision, and it's thought to be due to inflammation. Most of the time, cystoid macular edema will go away even on its own over a period of months, but usually we will give a steroid injection to the outer coat of the eye that helps to speed that recovery process. It's not a common complication, but it does occur in about 1 patient out of 100. Another possible complication is a detached retina. This is also a serious problem where the lining of the eye, the retina, has actually come loose from its attachments to the outer walls of the eye. If this were to happen, you might experience a dark curtain accompanied by a lot of floating spots and flashing lights, and we would need to send you to a retinal specialist to have that repaired. In most cases, it can be corrected. Retinal detachments occur in less than 1 out of 100 patients. Sometimes we can get some unwanted reflections or shadows off the implant itself called dysphotopsias. Please keep in mind that lens implants are man-made. They're not quite as good as the original designer's lens that you were born with. So it is possible to get little reflections or shadows, sometimes described as dark crescents in your peripheral vision. Sometimes these will go away on their own, sometimes they're permanent, but we do have to accept that possibility with a man-made device. Also, it's possible that you might experience corneal edema or swelling of the cornea, which is very common on the first day or 2 after surgery. Since time doesn't allow me to list every possible complication, naturally this is an incomplete list. Now, please keep in mind that cataract surgery fixes cataracts. So if you have a pre-existing condition such as macular degeneration or a macular scar or diabetic retinopathy problems, it's possible that your vision may fall short of 20/20 because of these other problems. You can only have 1 cataract in an eye. You can't have more than 1 cataract. You may have more than 1 spot that's cloudy in the lens, but we still correct it the same way. Once your cataract is removed, that's permanent. It will never come back. However, there is about a 50-50 chance that you may develop a little protein film that can form across the posterior capsule, and it usually takes 1 to 2 years for that to form. However, it is fairly simple to correct. We use a laser called the YAG laser. The YAG laser is a no-touch technique where we shine the laser in through the front of the eye, and it vaporizes or opens the posterior capsule. Once that's done, that's permanent. So it's a fairly simple cure for that problem. Let's talk a little bit about what's going to happen on the day of your surgery. We like to do our surgeries in our facility if possible, but sometimes because of insurance reasons, we have to go to a Penrose or a Memorial facility. Certainly an advantage is that here at the Wright Eye Center, our center is state approved. On the day of your surgery, you will need a driver because you'll have been given some sedation and you will just have had your eye worked on, so you will not be able to drive yourself home. Guidelines as far as eating or drinking will be given to you in writing, and that depends on what time of day you're having your surgery. We do our surgeries under IV sedation. You will not be put unconscious, but if you're very apprehensive, we can actually make you very drowsy and sleepy while the surgery is taking place. You will be in our building for 2 or 3 hours from the time you set foot in the front door until you're actually leaving. The surgery itself takes about 10 minutes to perform. After surgery, there are 2 main precautions. I'd like you to avoid rubbing your eye vigorously. You can still take a Kleenex and blot the inside corner, or if you're touching around the lower lid, that's not a problem, but avoid getting a knuckle and rubbing on the upper lid for fear of causing a wound leak. Secondly, we want you to use good hand washing. We want you to avoid contaminated water like swimming pools and hot tubs. Showering has never been a problem. You'll likely keep your eye closed in the shower anyway. Bending and lifting used to be a problem with older style surgery. It's no longer a problem with the way we do surgery now. Since there's no bleeding with cataract surgery, patients who are on blood thinners do not have to stop their medication. You will be sent home with a clear eye shield taped over your eye. You'll be able to see through that shield. We'd like you to leave that shield on throughout the day that you have your surgery, and we'll use it only at bedtime then for about a week following that. You'll be given written instructions on how to use your eye drops and what the frequency is and for how many weeks to use them. If you have house pets or horses or livestock, it's okay to be around them, but again, we would ask you to use good hand washing before you touch your eyes or before you put drops into your eye. When you come in on the first morning after surgery, your vision probably is not going to be perfect. You may have some swelling. It takes typically a week or so for swelling to diminish. And one of the most common questions I get from patients is, what will I do with my old glasses on the first day? Do we pop out the lens? Do we leave the lens in? And my answer is, we won't know until you come in. We'll have to see how well you're seeing with the naked eye, and then we can make a determination as to whether to just leave the old lens in as a protective shield or to pop that lens out and let you go without the lens. Well, in closing, I know that this is a lot of information that we've presented to you today. If you would like to have this information on a DVD, please ask our staff. We'd be very happy to give you one. If you have other questions, ask me or my staff, and we do want to make sure that you understand all this information before surgery. So in closing, I am very pleased to have you as a patient, and thanks for choosing the Wright Eye Center.